Good morning. Diabetes is becoming popular day by day with growing numbers of patients and a drop in the age of its patients. In 2007, 246 million people have diabetes and 4 out of 5 are Asians. Today we have an opportunity to talk with our speakers who will explain us about the diabetes and its symptoms, including a new drug that has just been discovered. Our first speaker, Dr. Friedrich Wilhelm Kuhne, the inventor of immunokine WF10 and the founder of Oxochemy Thailand. Our next speaker is Dr. Arnold. He is the professor of biophysics and biochemistry and an expert of red blood cell metabolism, one of the very few worldwide. His latest publication describing the therapeutic inactivation of cytotoxic hemoglobin metabolites by the WF10 is revolutionary. And our last speaker is Police Colonel Surgeon Phaiboon Maraphriksawan. He is the cardiovascular thoracic surgeon, general surgeon at the Police Hospital, Thailand. Let's talk about the diabetes. Can you please tell us about what diabetes is and what makes us sick from being diabetes? Dr. Kuhne, can you start?
I'm not a diabetic. I'm also not a diabetic doctor. But I know what the mainstream knows about diabetes. Too much sugar in the blood. So a lot of drugs available to control sugar. If too much sugar, there is one hormone with the name insulin. So insulin is like a messenger boy. It took the sugar out of the blood and transport it to certain cells. So 3 types of cells: hepatocytes, fat cells, and muscle cells. So these cells are called insulin-dependent cells. But there are much more cells in our circulation system ready for glucose to enter. And this is what we are talking today. When you speak about diabetes, the sugar alone doesn't make you sick. I have a lot of sugar in my body. It's used everywhere. But if over long term, too much sugar, called it glucose, circulate in our blood, this sugar molecule can hit red blood cells. So the red blood cells are not millions, are billions circulating in our blood. What happens if the sugar molecule hits the red blood cell? That is the job my friend Dr. Arnold has to do, to explain to you.
Okay, as Dr. Kuhne told, glucose molecule is very important for all cells because it is needed for the energy production. And in red blood cells, you have an uncontrolled uptake of glucose molecules, and in diabetic patients with a hyperglycemia, there is an enhanced uptake, and so you have a higher intracellular level of glucose. Any threat of this molecule depends on the consumption of the glucose in these cells. When there is a high amount of energy needed, glucose is easily consumed, and so is not so the serious problem. But in many cases, the energy it is not necessary to produce so much energy, so you have an enhanced level of glucose, and this glucose is an active molecule because usually in textbook is a molecular structure given as a ring form. But this molecule exists also in an open known ring form, and this open known ring form has an active bioactive chemical group, in so-called aldehyde group, and this molecule can induce any Favor reactions. For example, an attachment of glucose to proteins, to lipids, and to other molecules. And so you have a so-called glycosylation or glycation. There's a complex set of biochemical reaction induced after this. And so the normal function of many biological proteins will be disturbed by these post-translational reactions.
Professor Arnold, what is the sugar molecule doing with the red blood cell?
Okay, there are several aspects necessary to consider. One aspect is that hemoglobin, this is the most abundant protein in these red blood cells and necessary for oxygen transport, becomes glycosylated. And there are several target sites, and there are some subforms described, and one subform is a hemoglobin A1C. This is an important parameter to predict or to evaluate the glycosis levels in these cells.
Damage in the red blood cells?
In the red blood cells, yes. And so forth. This is now a well-known parameter to control the hyperglycemic state in patients, in diabetic patients.
I have a question to Dr. Paboon. Dr. Paboon, when I went to Concan 2-3 years ago, when I spoke to the servants treating diabetic foot ulcer, no one has known about HbA1c.
Oh, yes.
How is that?
Let me simplify on diabetic disease. In the human body, all the cells require energy, which is supplied by glucose. And when the cells utilize glucose, they need insulin to help the glucose penetrate into the cell and convert into energy. So in diabetic patients, the insulin hormones cannot produce enough by the pancreas, which is one organ in the abdomen. When insulin is not sufficient to utilize glucose into the cell, into energy, this will cause high blood sugar because it cannot penetrate into the cells. When the high blood sugar level in your body stands for a period of time, for instance, 1 week, 1 month, 2 months, 3 months, this will bind, this high glucose level will bind to red blood cells. So don't forget, red blood cells is the highest number of protein in your body, not only carrying the oxygen to all the cells to survive, it's also bind to glucose. This we call hemoglobin A1C. So most of the doctors, especially for internal medicine specialists, use this hemoglobin A1C level to monitor the behavior of his patient, how good this patient can control his blood sugar for the past 3 months, because lifespan of the red blood cell is 3 months. So when they bind, it never goes to anywhere. It will circulating in your body. So this lasts for 3 months.
Dr. Paboon, why they use just the parameter in the red blood cell, not in the plasma?
Yes, because when they bind, you can detect whenever you do the laboratory testing. But your plasma will vary all the day, all the time. When you eat something, when your glucose absorbed from your intestine, that's the time your blood sugar will get high. So this is the reason why. And normally, when the diabetic patient require the treatment to utilize glucose, so when their pancreas can still produce insulin, but not enough. So we use the tablet to enhance the pancreas to produce more insulin, just enough to utilize glucose into the cells. But when that patient cannot use the tablet for one reason is the pancreas is too exhausted, so they cannot produce insulin enough. So this is the time to control glucose with exogenous insulin by injectable insulin to substitute the production of their body. So most of the anti-diabetic drugs and also insulin, most of the study are aimed to the insulin receptor in the cells. As we talk about that insulin enhance the cells to utilize glucose by make the glucose can penetrate into the cells and utilized by the cell into energy. So all the studies will concentrate on the insulin receptor instead of how sugar binding to the red blood cell, which is make the red blood cell malfunction. And this is the explanation of Dr. Arnold.
Excellent explanation by Dr. Paboon. I had something else in mind. Why just using HbA1c as a parameter to monitor glucose control?
Okay, for glucose control it is a very nice parameter. In answer to the question of Dr. Paboon, I have to tell that the insulin receptor for the glucose uptake is not present on all cells in our organism, only on liver cells, on muscle cells, on fat cells. But there are a lot of other cells, some endothelial cells, neurons, and especially red blood cells have an other transporter for glucose molecule, and this transporter is insulin independent. And that means you have an uptake of glucose by these cells independent of the level of insulin, and the uptake is higher when the glucose level is higher in the plasma, of course, and it depends on the consumption. And so many diseases associated with diabetes, for example, retinopathy, neuropathy, diabetic foot syndrome, and others, are related to the uncontrolled uptake of glucose by these cells, especially in erythrocytes. And this is necessary to know, because in textbook usually, I am totally agree with you, there is only the speech about insulin dependent uptake.
So that means that HbA1c, this parameter, is not only a parameter for sugar control, it is a parameter for prediction of death and blindness and kidney failure, and also to lose my leg. Is that correct?
Of course, there is some truth. It is necessary to look on the details, of course. And here it is necessary to understand what happens in the red blood cells and other cells where the uncontrolled uptake occurs. We have not only a glycosylation and glycation that leads to enhanced levels of HbA1c, for example. We have also in red blood cells an activation of other enzymes. For example, there is an enzyme aldose reductase that converts glucose into another sugar molecule, into sorbitol, and further into fructose. And these molecules, sorbitol and fructose, are impermeable through the plasma membrane, and these cells becomes in turn osmotically unstable, and they are prone to hemolysis. And so it can happen one very bad thing for the cells, that some red blood cells becomes hemolytic because they have a mechanic stress during the circulation and so forth. And so any hemoglobin can be released into the plasma. And then you have other events of physiological reactions that can occur that contribute to cytotoxic reactions.
So you mean that this is the explanation why the diabetic patient have very strict control on using insulin to control their blood sugar, but still in long term there is a wear and tear effects on the inner wall of the vascular, whole body vascular. So as we observe in the clinical, if the patient have been suffering from diabetes for 15 years, and this is a time all the problem from vascular disease, don't forget, every cells, every organs in the body composed of vascular supply to the organ, otherwise it cannot survive. So if we consider all the vascular in the body is very big surface area, the inner wall. And once the inner wall was toxic due to the non-insulin dependent process, this is a time all the vascular will be degenerated and have some atherosclerotic, like what we have seen, calcification after we got the cholesterol plaque or degeneration of the inner wall of the vascular. And this is a time all the organs will be affected. For instance, kidney disease, because kidney, they contain billion of vascular, very tiny vessel to do filtration of the waste product of the body. The second one is retina. What we can explain, the retina, no doubt, when you got a high blood sugar for a very long time, 15 years, 20 years, that's the time your patient will suffer from retinopathy, so it will cause blindness due to diabetes. This is an explanation of Dr. Arnold. Professor tried to explain why the process of diabetes have effects to the complication of diabetes patient.
So I think we have a very good big picture about the red blood cell, how it relates to diabetes and the HbA1c. So now let's move on to WF10. Dr. Kuhne, we're wondering what is the inspiration behind the research and the invention of WF10, and how is it different from other treatments for diabetes?
This drug, WF10, is called in the publications chloride-based drugs. And chloride is one inorganic molecule. This is his job to explain this more in detail. This molecule was developed for many years for treatment of chronic inflammatory diseases, because all papers, all scientific involvement was focused on white blood cells, on macrophages, dendritic cells, natural killer cells on one side, and on T cells, B cells on the other side. The discovery that the red blood cells might be the target cell for this chloride molecule has been made by this man, because he treated with this molecule diabetic foot ulcer, and one day he came and said, "Oh, Dr. Kuhne, this drug might have an anti-diabetic effect." I said, "So what?" "Yes, because one patient had a high sugar level of 350 milligrams per deciliter. I gave him infusion with WF10, and suddenly he nearly came into hypoglycemic. That means too less, or not enough sugar. So she had to give him some sugar to come back to the normal level." So, and then we started to investigate what is going on there. So this molecule is very simple in its chemical structure, but fascinating in its reaction with the red blood cell, with heme protein. So that becomes too technical now.
On clinical point of view, this product have been introduced into the market firstly by the local wound treatment because the property of reduce inflammation and infection very rapidly and good control. And since 1997, Thai FDA have been approved for the injectable of immunokine WF10 as the treatment for radiation cystitis. You can imagine when the patient have undergone radiation treatment due to cancer, especially the lower abdominal radiation, and your urinary bladder will be affected. And that's the time they got a severely red urine, what we can say in layman term, is bleeding in your urinary bladder, and this is a deadly disease. And so far there is no existing drug can treat that symptom and disease. And here come the WF10 infusion, and this inflammation and bleeding can stop within 3 days. And the FDA, knowing that that effects on the study, and then eventually they approve for Thai FDA registration since 1997, and have been approved for safety monitoring after that for 3 years after it's available in the market. And since that time, due to the good effects on infusion into the venous system, knowing that it's very helpful in inflammation and infection, especially gas gangrene, necrotizing fasciitis. If you see it, you will not believe that in human being can be such a worse infection, because this is life-threatening, because that bacteria will go into your bloodstream and cause the patient die within few days due to immunology response or immunology defense mechanism. And that's the time we start to use on that critical patient, and the patient have been improved on the inflammation and infection within few days. So as we know, for diabetic foot ulcer patient, when they got infection, it is so serious and very difficult to control infection due to many factors for the diabetic patient. For instance, immunity to control bacteria infection, to get rid of that bacteria, and secondly for the high blood sugar, and thirdly for the microvascular problem on long-standing diabetic. That's the time we start to use immunokine WF10 as a conjunct therapy to the standard treatment. What is the standard treatment? Yes, all the surgeons and doctors knows, wound dressing, clean every day, antibiotics, blood sugar control, because once you got infection and wound on your leg, this is a stress to your body to require more insulin. So this is normal practice. But still, that normal practice cannot combat infection and inflammation. So this is the time most of the surgeons propose to amputate the lower limb to save the patient life. That's the normal principle of surgery. Here come immunokine, can control the infection and inflammation and save life without amputation.
What is the mortality after total amputation?
Oh yes, actually amputation per se or itself have no effects on the lifespan of the patient. But this is the iceberg that we can see on top of the sea level, that once the patient got diabetic foot ulcer, it means that here come the vascular problem. The whole body of the patient vascular have problem already. You can imagine such kind of big enough vessel on your leg have been affected? How come your very tiny vessel on your retina, in your kidney, and the whole body, entire body of your very small vessel will not be affected? And this is a term, and this is the warning signal that the patient have now the problem of the whole body vascular problem. And this is the reason why when the patient got amputation, mortality rate from diabetic complication is supremely higher than normal individual. It's more than 20% compared to normal individual at the same age. And here come once we have been studied for diabetic foot ulcer adjunct therapy to the standard treatment. After we correct the data, the Thai FDA have been approved for the diabetic foot ulcer adjunct therapy for this immunokine WF10 since 2012. And that's the time we start to use as the adjunct treatment of diabetic foot ulcer. So that when the patient got to know, when the doctor proposed amputation, whether below knee, up, or above knee amputation, the patient and their relative try to save their limb by themselves, search for the information, and here come them. When they found the study of WF10, they come. So we can save the limb. And once we do the treatment, according to the observation, after we give the WF10, try to save their life, their legs, that's the time I have to reduce all the medication to control blood sugar more than half. Otherwise, the patient will get hypoglycemia, low glucose. Yeah, definitely if you give the same medication to control high glucose. But this time, I have to reduce the blood sugar control regimen. Otherwise, the people might die of very, very low glucose. And here comes the question that how immunokine affects to the patient to control blood sugar better than ever before.
That we come to the blood cell.
Yeah, here come back to the explanation, Dr. Arnold, Professor Arnold.
So from Dr. Paiboon explains, WF10 not only offer diabetic patients to avoid the amputation, but also promote the better condition of blood sugar control level as well, and hence give them a better health condition that relates from the diabetic condition. Is that correct?
Oh yes. Since I have been as a clinician practice for more than 30 years, I have never seen any treatment that can enhance or lowering of hemoglobin A1C level, such kind of very rapid lowering of hemoglobin A1C. And on the other hand, the blood sugar control is better as well. And this is one of the breakthrough knowledge that we have found. It's never happened before in the medical science. We can never see such kind of any treatment that can control hemoglobin A1C. This is the reason why most of the clinicians, they will detect or monitor hemoglobin A1C every 2 to 3 months. As we know, the lifespan of the red blood cell is lasts for 3 months. It's no use to check your hemoglobin A1C level on this day and next week and the other weeks, because it's still the same. What they believe is still the same all the time until the 3 months that red blood cell have been destroyed and eliminated from the body. That's the time your hemoglobin A1C will drop down, provided you have a very good control for this coming next 3 months. Otherwise, your hemoglobin A1C will getting higher and higher because it always produce coming back again. Yes, Dr.
Interviewer, may I ask to Professor Arnold one question? Dr. Paiboon just mentioned that the sugar came down so dramatically. Where is the sugar gone?
Okay. First of all, I have to mention that the hemolysis that undergoes red blood cells is very dreadful for the organism. And this is a process that develops step by step, gradually, because there exist some protecting systems against hemolysis, but these protecting systems in form of some plasma proteins are limited, and they are rapidly exhausted. And after this, you have an accumulation of very toxic breakdown products of hemoglobin. This is the so-called hemine. This is the heme group with iron inside. And this is a very hydrophobic molecule that inserts into lipoproteins in the biomembranes, and this molecule is responsible for the vascular effects and so on. And hemine has also a very another property. It can itself induce hemolytic events on other red blood cells. So you have such kind of a viscous cycle that you have a toxic product, and this toxic product produces novel hemolytic events. And this is what happens, and this is a very strong condition observed not only in diabetic patients, also under condition of sepsis you mentioned and so on, and this contributes to a high mortality and other things. And so it is now important how can chloride, which is a component of WF10, act, because it interacts very easily with heme proteins and also with hemines, and by this way it inactivates the catalytic reactions by these proteins, and so it stops rapidly all these hemolytic events, and so you have no novel induction of hemolysis. And another effect of is you have also in diabetic patients a number of highly disturbed red blood cells with reduced redox state, and in these cells WF10 causes something like apoptosis, a cell death, and these cells are removed from the circulation. So you have also a removal of pre-damaged cells, followed by a higher proliferation of novel cells. This is really observed. And in these pre-damaged cells, you have usually a very high level of hemoglobin H1C. And so these cells are removed, and this contributes also to a drop down of this parameter. And another effect is this is also in the whole textbook, in textbooks about diabetics is written that a low energy metabolism of patients is responsible, and so they have vascular problems and so on. And this is because and a higher blood pressure and also on. And this is because nitric monoxide, an important molecule what is necessary to dilate the vessels, has a reduced bioavailability. And this happens after hemolysis. Nitric monoxide is consumed by hemoglobin released from red blood cells. So it cannot contribute to the relaxation of vessels. Yes, and so when you stop all these hemolytic events, you have also a better bioavailability of nitric oxide, and this is also very good for the patients. And there is another detail necessary to know. The accumulation of these osmotically unstable components like sorbitol and others, depends on also on the bioavailability of nitric monoxide. When you have a normal bioavailability, you have a low level of sorbitol, because this enzyme in red blood cells, what is responsible for the formation of sorbitol, is regulated by nitric monoxide. And so you have a complex set of reactions that contribute to the improvement of the vascular state in these patients after application of WFT.
We have seen in wounds, also in diabetic wounds, after WF10 infusion, a wonderful granulation tissue. So we interpreted this as a better circulation.
Yes, of course. And this is what really happens.
Yeah.
No?
This is the explanation. When the clinical outcome, yes, we know is better, but we still don't know why and how. And this is the explanation why. Because, yeah, the key problem is hemine that release into the body in your body after the breaking of the hemoglobin A1C. It produces hemine accumulation in your bloodstream, and this is a toxic substance to make your blood vessel getting worse. Your blood vessel in the wall will be degenerated and cause stenosis or occlusion in finally, and this is all the problem of blood supply to your organ. This is the effects of the long-standing diabetes.
Yeah, and this highly depends on the level of nitric monoxide.
Correct.
Dr. Prabhu, you mentioned about insulin as a standard of care, as a stringent glycemic control by oral antidiabetics and insulin. That is simply a law. But despite that, we see a lot of people with high HbA1c, and we see a lot of people with diabetic foot ulcer and kidney problems.
So it means once we can control such kind of degeneration process, and that's the time we can help them to prevent any complication for long-term complication, wear and tear problem of diabetic patient. So it doesn't mean that we can cure diabetes, but it means that we can extend for diabetic patient before they will get the complication, cutting their legs, having blindness, having kidney problem, they have to go for dialysis all the time. And this is, we can delay of degeneration of the problem.
So WF10 is a treatment that improves healing in diabetic foot ulcers. But can we say that it also helps improves the health of the diabetic patient in general as well?
Yes, correct. And this is a new observation and a new breakthrough, what we mean control of diabetic problem. Please don't forget, for diabetic patient, their quality of life is so difficult. You want to eat a piece of cake, you have to think about your blood sugar. You want to do as usual in your normal life, you cannot. You want to eat some fruit that you like, it cannot. You have to control your blood sugar all the time. Otherwise, your complication will come earlier.
Also one additional answer to your questions is that more insulin does not solve the problem. If you increase the insulin titration more from 60 to 80, it does not solve the problem of sick red blood cells. There now we hope to offer the treating physicians an exciting therapeutic options with immunokine. That is our message today.
Yeah. Because no doubt, no wonder, there are some or many patients that we have to increase all the time for the insulin treatment to control their blood sugar level. But still, their hemoglobin A1C and their diabetic control problem still cannot be controlled because there are some factors that's not an insulin dependent factors that we can control. For the past years of the knowledge of diabetics treatment.
Dr. Prabhu, I read a report from the Minister of Public Health during the time Dr. Pavit Boravit was in charge,
Yes.
recommending HbA1 measurements every 6 months.
Correct. That's a normal practice.
In this report, it is a very important report for Thai population. It is recommended to reduce HbA1c by at least 1%. How much could you get down with HbA1c?
It varies according to the normal theory that we have to control the blood sugar lower than 140 or 110 for a period of 3 months. So it means that the new red blood cells which are produced from your bone marrow will not be affected by glycation or glucose level very high, and doesn't have, it takes 3 months to 6 months before your hemoglobin A1C drop down. So yes, there are many studies regarding to the percentage of hemoglobin A1C drop down, 1% drop down. It can reduce your risk of the complication. For instance, your risk of amputation of diabetic foot ulcer reduce 47% reduction after 1% of hemoglobin A1C drop down. Kidney problem reduce about 6%, 5 to 6% reduction after your hemoglobin A1C level, for instance, from 7 to 6, your risk of your nephropathy or kidney disease will reduce about 5 to 6% every time when your hemoglobin drop from 1% drop.
So is it correct to say that what makes WF10 different from other treatment for diabetes is that it targets at the roots of the problem, which is the red blood cell? Is that safe to say that?
Not totally. It's only one pathway for diabetic control. You still need insulin or all kind of treatments for diabetics, including your diet control. This is the root of the problem as well.
I didn't understand your question. Can you repeat your question exactly? I didn't understand.
Oh yeah, please again.
I was saying, is it correct to say that what makes the WF10 different from other treatments for diabetes is that it targets at the roots of
That is the target. The target. The target for WF10 is the red blood cell, not the pancreas or the insulin dependent cell. The target is the red blood cell. And Professor Arnold explained endothelial cells, but mainly red blood cells, because the red blood cell becomes sick under hyperglycemic conditions. Everything is disrupted, produce radicals, toxic, bursting, and then immunokine hit it, calms it down, and at the same time generates new red blood cells from the bone marrow. Beautiful.
And
Fantastic.
red blood cells contribute to the complications in diabetes, especially to vascular complications and all other complications well known, and WF10 interacts with these toxic products of red blood cells, and so we have these very good effects.
So it means that this is the adjunct therapy to control diabetes, not the main. With the combination of the former treatment or standard treatment of diabetes, and this is the adjunct to help.
So WF10 is the adjunctive treatment to the standard treatment of
Correct.
diabetes.
No, Dr. Prabhu, there I would dispute. A standard of care is a must.
Correct.
I'm not a clinician, but I'm seeing it more from the theoretical point of view. That is a must. But if you have an HbA1c of 10 and 14, you cannot,
Correct.
that you mean you want to have a young to standard, then I agree with him. If you think you have to continue with your standard of care plus WF10, I'm a little bit in my belly, feel uncomfortable because I think he too, because the sugar would drop too much. And then you have to reduce.
Correct.
Is that correct? Yeah. Otherwise, it's only minor point. I would say if someone has HbA1c above 10, the endocrinologist should use this drug definitely to
And especially when there are complications, vascular complications, and not each diabetes patient has these vascular complications. But when these vascular complications are developing, then it is necessary to look for how is the hemolysis degree and so on, and then to use WF10.
Correct.
A lot of studies have to be done. So we all talk, we need the academic institutions in Thailand to do some more studies in patients without the diabetic foot
Correct.
ulcer, but with a high HbA1c.
That's right. Because no doubt, and so wonder, in many cases with mild diabetes, so not that high, and once it have been treated with the WF10, they don't require any insulin treatment or the tablet at all. The insulin injection and for a period of time, after a few months of the treatments, and it means that maybe their defect is on such pathway, not because of their pancreas cannot produce enough insulin. So their pathway is that defect.
Do you have anything to add on?
Yeah, I'm seeing it more with the eyes of a healthcare thinker. What will be the future? How you can reduce the suffering of people with long-term diabetes. It's a terrible story in the families and everything. And there, my dream in my life, all our dream would be to prevent people from going too much to hemodialysis centers, because that is a terrible development. Every day, we have 7 more patients in Thailand going to the hemodialysis.
So you mean the new cases?
Yes. So, and there I hope in more studies, but there we have to do a lot of work. We need, it's a big challenge.
On behalf of also Chemi Thailand, I would like to thank you, all of our 3 speakers here for your time and your very informative discussion today. Thank you so much.
Thank you
also.
for